Good afternoon, everyone. I am Mrs. Egieyeh, Elizabeth Egieyeh, as you can see on the screen. So I am your fourth term lecturer. Okay, so I'll be taking you through the topics we have to cover in fourth term. And we are actually on the timetable, on the schedule. We asked us to start with CNS disorders. Okay, but I was made to understand that you had already done psychiatry, pharmacology, which sort of covers a bit of what you needed to do in CNS. Okay, but I'm going to start with something that is also on the CNS, analgesics and anti-inflammatory agents. Okay, it's still on the CNS, but since you've done all those psychotics and anxiolytics, but I'll go and see if we missed out, if Dr. Van missed out anything, then I'll bring that on. Okay, but I'll start with analgesics and anti-inflammatory agents this afternoon. So, I'm sure we're all very familiar with the term analgesics. I feel very awkward because I'm standing right in front of the screen. I don't know which way to go. Okay, so I'm sure we're very familiar with the term analgesics. Or is there anyone who isn't familiar with those terms or with that word, analgesic? Okay, who is familiar with the word analgesic? Okay, please could you quickly tell me what it means? Okay, you're right. Carry on, okay? So it has to do with pain. It's a word that has to do with pain. Okay. Okay, so that's the slide here. So it's a word that has to do with pain. So analgesics and anti-inflammatory agents are two classes of drugs that deal with pain. All right. Analgesics deal with the removal or the reduction of pain alone. Okay, so when you're talking about the removal or the reduction of pain, we talk about analgesia. Analgesia is the removal or the reduction of pain, and that's where analgesics originates from. So that is, they're called painkillers. When you hear the word painkillers, then we're talking about analgesics. And then we'll see an example. Paracetamol is an example of a painkiller. But we can differentiate from anti-inflammatory agents in that anti-inflammatory agents have the ability to relieve pain and also to reduce inflammation. So your analgesics do not have the property to remove inflammation, but your anti-inflammatory agents would be able to remove both pain and inflammation. Both of them can reduce pyrexia. Pyrexia means a fever. Both of them will work for a fever, but the difference is that one would work on pain associated with inflammation, while the other just works on pain. So if there's pain, there is a swelling. A patient has pain with a swelling, you want to immediately think of an anti-inflammatory analgesic agent. So it will work on the pain, it will reduce the swelling at the same time. But if you just give an analgesic agent, it will relieve the pain, but the swelling is still going to be persistent for a while. You're not going to help it to go off very quickly. All right, so when I look, this slide is supposed to be our study outcomes. But apparently, we need to use a PDF copy. Because I just took a picture. This is in your textbook, Pharmacology for Nurses by Denver. It's there. So while we, for today, we have a lot to do. We need to go through all of this today. I hope we would be able to do that. So we need to be able to, because we're talking about analgesics, we're talking about pain, we're talking about anti-inflammatory agents, we're talking about inflammation. We need to be able to, at the end of this class, explain what this really means. And we'll see the different, you did autonomic nervous system. In autonomic nervous system, you came across neurotransmitters. Do you remember? Yes. You came across neurotransmitters. I'm sorry, I need to be close to the camera. You came across neurotransmitters because the way our body is created, messages are passed from one neuron to another all throughout the body. If you remember your ANS, throughout the body you have nerves, running all throughout the whole body. And then messages and signals and impulses are sent from one part of the body to the other through these neurons via your chemical mediators. So the neurons are not particularly, like if you form a chain here, my hand touching your hand and you touching that, then we can pass the message across, isn't it? But it doesn't happen that way. There is a synapse. Do you remember the synapse? So it's the neurotransmitters that carry the messages across the synapse. You remember what your synapse is. So that's the function of neurotransmitters. For analgesics and anti-inflammatory agents, we have what we call mediators, chemical mediators. These chemical mediators are the ones that carry messages, or that not necessarily carry messages, that help to create an environment, influence the system. You remember homeostasis as well in autonomic nervous system, the steady state of the body, that help to tell the body that there's something wrong somewhere. Okay, so these chemical mediators tell the cells, the tissues, the immune system, there's something wrong somewhere in the body. We need to do something about it. And then messages are flying to the CNS, to the brain, to the spinal cord, and the spinal cord interprets the messages and sends these messages, sends a response. So we have our afferent neural system, nervous system, and then we have the efferent nervous system. Afferent takes the message to the CNS. Efferent brings it back to the peripheral nervous system, where the muscles, the GIT, and all of those things can now act in response to the message the brain has received. So we have chemical mediators playing that role to inform the body that something is wrong and we need to sort it out. Okay? So that's what. So these are the things we need to know. We need to know about as we go on, you know about prostaglandins and thrombosis. So if we're going to have a test or the exams, the finals, this would guide me in setting my questions, because this is what we need to know, and we only ask you what we need to know. So in knowing, you would know from listening to the lectures, from reading your notes, and also reading the textbook that we have, because we are trying to limit ourselves to the textbook, so you don't have too many places, too many resources to run to. You just have one, and you can be sure that whatever we're talking about is from that resource. So we have the lectures where we will talk and expand and expound on whatever topic we have to discuss about. Then you have the textbook. Then we have quizzes as well. Okay, we have quizzes, and there will be tests. So if we work together to be in class, to listen, to follow as I'm talking, to write down, because I might just remember something that I want to share with you that will make you understand it better. So write down as we are in class, also to do the quizzes that I'll put up. I'll try and put up my quizzes on Friday mornings. We will run through the weekend, but you'll have practice quizzes, the same model as Dr. Van Estin. I'll try and do the same so you can have access to enough practice questions. All right, so I'll do that. I'll put quizzes on, and if we do it and then we prepare we do our tests, we should be good for the exams. Okay? So I'll do my part. You also need to do your part so that you can come out glorious. Okay? I don't need the grades, but you guys do need the grades. All right. So you can go through this to just know what we need to know in this class. Okay. All right, so that's that. So we said analgesics refer to pain. Okay, and anti-inflammatory agents also has to do with pain. Inflammation is actually an event that notifies the body. That's what is called the inflammatory response. The inflammatory response notifies the body of an invasion, okay, an obstruction, an incursion in the system. And so when that happens, and pain usually accompanies inflammation, when that happens, the body now realizes that our security has been breached and we need to tighten the noose. So pain, it's difficult. Can anyone define pain? Can we define pain? Anyone try to define it? A feeling of discomfort. Unpleasant sensation. Unpleasant sensation, a feeling of discomfort. Okay. Anyone else? Noxious stimuli. Unpleasant. Still saying it in another word. Saying it. So it's usually a response to an event that is not natural, not pleasant to the body. Okay, so it's in response to an event that is not. And another way that you would have pain is through tissue damage. If you had a break in the skin, you hit your head somewhere, you hit your leg somewhere, accidents, any trauma to the body would also cause pain. And it depends on, we have different thresholds and intensities for pain. Some person will hit their head against this pole and move on, just rub and move on like nothing happened. Some person will hit their head against this pole and sit for the next 5 minutes. Am I right? Because we have different pain thresholds, okay? And we can the intensity, we can accommodate the intensity in different ways. I already talked about that. So, analgesic agents are agents that relieve pain. They basically relieve pain. There's what is called the mechanism of pain and nociception. The mechanism of pain and nociception. So, nociception basically is the way we experience situations that are unpleasant. The way we experience, so someone hits their head against a pole now, is an unpleasant experience that causes pain. So that is a nociception for that event. So for you go to ANS, you also I'm sure you also know that for every part of the body and for the different systems, there are specific receptors. Okay? For the systems of the body, and the different parts of the body, each part has its own receptors to which drugs can bind, okay, to cause an action. And so through which, like for your, the chemical mediators, the neurotransmitters in ANS, the neurotransmitters need to bind to receptors in the synapse on the postganglionic fiber from the preganglionic fiber. They need to bind to receptors. So there's always an interaction between receptors and chemicals, and that is the basis for drug development. Because we realize that when a chemical binds with the receptor, it causes a pharmacological action that can elicit pain, that can cause a change to a disease. And so that is the basis of drug development. So we find these receptors and we look for what can bind to them to reduce pain or to cause the progression of a disease. And then you look for the synthetic chemicals that can work on attached to those receptors as well and cause the relief of disease or pain. Receptors are everywhere in our body, and they're specific. So you have the ones that are in the arms, the ones that are in the stomach, specific to those different areas, specific to the particular actions that they carry out. So for pain, pain also has its own receptors, and pain receptors are called nociceptors. Okay, pain receptors are called nociceptors. So the pain pathway, when a person encounters a stimuli, like hitting your head against the pole, the mediators, the nociceptive mediators, send signals through the neurons to say something has happened, all right, to this person, and the inflammatory process, which I wouldn't go into, your textbook doesn't allow us to go that far. Since the inflammatory process is generated, and messages are sent across that cause the inflammation and the pain that the person experiences during that encounter. So you would see that for pain, the pain mediators that help to pass the message to the CNS that this person has had an injury, we need to find a way of modulating that sensation, relieving that sensation. Because if you have you heard of necrosis, gangrenous conditions? What happens to the patients in such cases? Can they feel pain?
Yes.
They've lost, in gangrene, they've lost the ability to sense because the nerves are dead, blood is not being supplied to these areas anymore, so they can't feel. So if you put that foot in the fire, except it goes to a living cell, the patient will sit there and roast. Okay, so because the blood, the circulatory system is cut off from that gangrenous part of the body. That means our pain mediators are also not available because they work in the blood as well. So you see the different types of pain mediators. This is just some of them are listed on the screen there. Some of them are listed on the screen there. Maybe I should talk a bit about them. So we have histamine, acetylcholine. I'm sure you're very familiar. You're familiar with some of them from your neurotransmitters as well. Yes. Prostaglandin, which is from the arachidonic acid, substance P, and the other things that are there. So I'll focus on, for the nociceptive pathway, I'll focus on arachidonic acid. Okay, I'll focus on arachidonic acid. So it's a pain mediator. And we remember pain mediator, like I told you, compare their activity to that of neurotransmitters. So they help to alert the body of what is happening. Arachidonic acid is a compound from which a group of It is the fatty acid from which a class of compounds called eicosanoids are synthesized from. So your arachidonic acid, which is part of your nociceptive pathway, not necessarily as arachidonic acid, we'll see what happens to it before it participates in the nociceptive pathway as we go on. So the arachidonic acid is a polyunsaturated fatty acid. And from this arachidonic acid, a class of compounds are synthesized, which actively, so it's like, what do we call it now? It's like a substrate, or not a substrate, let's say it's not a substrate actually. It's like when you want to make cake, the flour, what do you call your flour? Pardon? A building block, yes. So it's like a main ingredient for the manufacture of the eicosanoids. It's very, very important that it is there. So, but it is not, this eicosanoids needs to be formed when the stimuli, like hitting your head against the pole again, when the stimuli occurs, the body quickly manufactures this eicosanoid to carry out to participate in the inflammatory process. So it is generated de novo. It means it's generated on site when it is needed. It's generated when it is needed. And one of them is prostaglandins. One of them is prostaglandins. So we'll see here, yes, when there's a stimulus and all of that, then that happens. So prostaglandin, one of them is prostaglandins, and another one is thromboxanes. The other one will be your prostacyclins and your leukotrienes. These are a group of compounds referred to as your eicosanoids, and these ones actively participate in the pain pathway. So arachidonic acid doesn't particularly participate, but it is used to form other compounds that actively participate in the nociceptive pathway. So what we see on my right side, I guess your left side, would be that arachidonic acid occurs in the body as phospholipids, all right? On the presence of a stimuli, it is converted by a phospholipidase A2 enzyme to arachidonic acid. So phospholipids in the body are converted to arachidonic acid by your phospholipidase A2 enzyme, and then arachidonic acid is acted upon by two different classes of enzymes. You have your lipoxygenase enzyme and your cyclooxygenase enzymes. So these two enzymes can act on the arachidonic acid formed from your phospholipids to generate the prostaglandins, thromboxanes, prostacyclins, and leukotrienes that are part of the nociceptive pathway. So this is the reason why I said your arachidonic acid is, what did you call it now? It's like your flour for baking. It's like an ingredient for the manufacture of your eicosanoids. So remember, eicosanoids are compounds that participate, chemical compounds that are mediators in the inflammatory or the nociceptive pathway. So when we have this synthesis of prostaglandins and all of those other eicosanoids, what really happens there? What really is happening there? I already mentioned that these eicosanoids participate in in the pain pathway and other areas of the body. They mediate in other pathways in the body, all right, to help the body to function properly. So you have prostaglandins are responsible. They participate in the pain pathway, in the inflammatory pathway, and they cause pain. Okay, they are responsible for pain, for fever, and for inflammation. Prostaglandins also help with uterine contraction for if the woman is pregnant and it is time for labor. So your prostaglandins need to be induced. So there are different types of prostaglandins, as you would have seen here. You have the PGD2, PGE1, PG1, the different numerous types, and each of them has a specific function. Also, you see with the leukotrienes, the different types. So you have different types of those mediators being produced. So prostaglandins are involved in the production of pain, fever, and inflammation, uterine contraction. All right. So if a woman is going to go into labor, prostaglandins need to be released, okay, attached to the appropriate receptors to ensure that the woman is able to go into labor. Also, prostaglandins also have a function in the body. So basically, I'm telling you about the functions of the eicosanoids, starting with prostaglandins now. Prostaglandin also has the function of helping with mucus protection or cytoprotection of the GIT. Cytoprotection of the GIT and the release of gastric juices in the gastrointestinal tract. What do I mean? We all know that we have gastric juices in our GIT. Why hasn't we, and we know what do we call them? Gastric acids. Are they acids? We have gastric acids in the stomach. Why hasn't it burnt out our stomachs since I was 20, 30, 40 years old? Why hasn't it burnt off or eroded our stomachs? I'm sure in high school we did chemistry and we know what acids do. Why hasn't it burnt off or eroded our stomachs already? Because the body also has made provision for the mucous lining of the GIT to be protected. And that is one of the functions of prostaglandin as well. So it forms and helps to secrete mucus that protects the lining of the stomach. So when the acid comes, the lining helps to prevent it from eroding the GIT mucosa. Also, I'm sure you've heard about ulcers. Ulcers occur as a result of an erosion of the lining of the GIT. And which means in that case, the prostaglandin in that person is not functioning properly. Thromboxanes help with platelet aggregation, and so the thromboxanes, you see when you do your hemostasis, yes, or circulatory system. What's blood flow called? What term is used for blood flow? How does blood flow in the body? So it's called a laminar flow. Human biology. You remember your human biology? It's called a laminar flow. Blood flows straight, it goes straight through the body. Except there is a disease, then you would have a turbulent flow in the body. So this happens because the platelets, the cells in the body, are moving individually. They're not clumping together. In the event that they begin to clump together, then the flow will be hindered. It will not be a smooth laminar flow anymore. So that's one of the functions of thromboxanes. Then vasoconstriction and leukotrienes are involved in bronchoconstriction. Bronchoconstriction is very important when we talk about asthma patients, because an asthma attack is usually set on when the bronchioles are constricted. So leukotrienes are very important. So inflammation and bronchoconstriction is one of the functions of your leukotriene mediator. Okay, so when we were looking at this, I talked about the cyclooxygenase enzyme acting on arachidonic acid to form your prostaglandins, and your lipoxygenase forming the leukotrienes. So what happens here is that there are three isoforms of your COX enzyme that act on your arachidonic acid to form your prostaglandins. Now we know what prostaglandins do, all right? So there are three of them, and each one of them acts on arachidonic acid to produce prostaglandins that have specific functions. So if you, COX-1 enzyme, acts on arachidonic acid to produce prostaglandins that are involved in the gastric cytoprotection that I just mentioned, also renal flow autoregulation, so it helps the kidney to regulate the kidney to function properly. That does prostaglandin as well. Then platelet aggregation done by thromboxanes, and you have your COX-2, which is responsible for production of prostanoids or prostaglandins that help with inflammation. Also, so the inflammatory pathway, when someone hits their head on the wall, the mediators are released, and inflammatory pathway is initiated to help heal and restore the body back to normal. So it tells the body there's something that's gone wrong. The immune system, if it's a bacterial invasion, the immune system comes out, your leukocytes, your phagocytes, they all come there to get rid of the invading organism. In the case of an inflammation, they help to stop the process of inflammation to restore the body back to normal. So your COX-3 is a new one, and its function is it's inconclusive as it is right now. So that's the function of your COX-1 enzyme, COX-2 enzyme, COX-3 enzyme to produce your eicosanoids, prostaglandins, and thromboxanes and leukotrienes. All right. So how does this affect your anti-inflammatory analgesics and your anti-inflammatory agents? How does what I've talked about, your COX-1, COX-2, COX-3, prostaglandins? What's the relationship between, we're talking about analgesics here and anti-inflammatory agents, so what's my business with COX-1, COX-2, COX-3? And anyone has it again, it gets to the relationship between these two areas, your COX and your non-steroidal anti-inflammatory. The enzyme, your cyclooxygenase enzyme, and careful, and the anti-inflammatory agent, and your COX. Anybody? I'm talking also about prostaglandin and anti-inflammatory agent. Can you think of a relationship between them? So I said prostaglandins function for, let's go back a bit. Okay, thank you. Did I go up now? Let's go back. We said prostaglandins help with, do we remember? Pain, fever. Thank you. So can you think of a relationship between your non-steroidal anti-inflammatory agent and your prostaglandins? What's the thread that puts them together? What are your anti-inflammatory agents?
You want to inhibit the inflammation, which is what the function of the
Yes. Okay, so that's it. So like I explained to you that the basis of drug discovery, okay, you know your answer, teaching this from a college. The basis of drug discovery is about receptors. I said that at the beginning of the class. It's based on cognitive receptors, chemical mediators, neurotransmitters. So it was found that these chemical components or substances can attach to a receptor and cause a pharmacological activity, cause a response. And if we can stop that pathway, then if that activity is undesirable, if we can stop that pathway, the chemical that is causing that, we can stop that unwanted activity from going on. So if prostaglandins cause fever, pain, and inflammation, if a patient has fever, pain, and inflammation, who do we need to get rid of? We need to get rid of the substance that is responsible for causing the discomfort. Okay? Like if you in your houses you have ADT and you have your security gates and all of that. Okay? If someone had been stealing from you and you wanted to stop them, you put that system in place. So it stops the person from stepping into your house and taking your stuff. So if we stop prostaglandin in that pathway, then we stop pain, we stop fever, we stop inflammation. But how do we stop prostaglandin in the pain pathway? From what I've said previously, how can we stop it? Huh? And listen, just pick out free class, no wrong, no right answers, we're all here to learn. Okay, so how would, remember the prostaglandin synthesis, the pathway for prostaglandin synthesis that I explained. How can we stop the synthesis of prostaglandin? Remember it's not naturally in the body, is when there is a stimulus, you hit somebody, and then when it says we need prostaglandin, prostaglandin is necessary here for this inflammatory process to go on, for the healing and the restoration of this part of the body. So how can we stop the synthesis of prostaglandin? Yes. How do the painkillers do it? Are the receptors fine? What? Anything else?
By inhibiting the synthesis of prostaglandin.
So what do we need to do to inhibit the synthesis of prostaglandin? How is prostaglandin synthesized? That's the question you need to ask yourself. How is prostaglandin synthesized? From
the aromatic acid and then the enzyme, the cyclox.
Oxygenase?
Yes. And then it produces the, that's where that is when it's produced. So I think if we can, from the
arachidonic acid.
Yes, so if we can stop the enzyme that produces, I don't know.
Good. Do we have our textbooks here? So do I have this one? What do we have here? What page is this? This is page 116. So if you look at page 116, it shows you the pathway for the synthesis of prostaglandin. So if we want to stop pain, we want to stop fever, we want to stop inflammation, we just stop the synthesis of prostaglandin. And prostaglandin is synthesized from phospholipids that are converted to arachidonic acid by your phospholipidase A2 enzyme. Okay? So phospholipidase A2 enzyme converts your phospholipids to arachidonic acid. Arachidonic acid is converted to prostaglandins by your cyclooxygenase enzymes, COX-1, COX-2, COX-3.
Yeah.
So if we can arrest cyclooxygenase enzyme, arachidonic acid will not become prostaglandin. And then we break that pathway. The pathway cannot continue. So pain will cease. And that's exactly what your non-steroidal anti-inflammatory agents do. So this tells you about inflammation, normal protective external symptoms of inflammation. Okay? So your non-steroidal anti-inflammatory agents reversibly bind or block the activity of your cyclooxygenase enzyme, okay, to stop the synthesis of prostaglandins and thromboxanes. Does it make sense to you? Does it make sense? So if we want to stop pain, stop fever, inflammation, and we know prostaglandin is responsible for that. If you know someone in the class keeps taking textbooks and forms and what, and we know who the person is, we can do several things. We can either tell them to call them to the university to take them away, okay, or we be careful and keep our phones very nicely and our things very nicely. So whatever we're doing, we are inhibiting the person from carrying out their enterprise. So we stop prostaglandin from carrying out the enterprise by stopping its synthesis from the, I'm looking for my biochemistry now, I can't find this substrate, I don't want to use substrate, but from its synthesis from arachidonic acid. So that is what your non-steroidal anti-inflammatory drugs do. So that is the mechanism of action, MOA, of your non-steroidal anti-inflammatory agents. So what is mechanism of action? Simply means how do they carry out their therapeutic activity. Mechanism of action, how does this drug carry out its therapeutic or pharmacological activity? And we see here just inhibit prostaglandins and thromboxanes. Okay. So we already know so because they do that, they stop inflammation, they relieve pain. So once the impulse for pain has stopped, analgesia comes. That's the relief of pain. Remember, analgesia is the relief of pain. I hope I'll be able to finish this lecture today. I think I'm taking my time. I don't have one. Someone tell me what time it is. Otherwise, you're...
25 minutes to 12.
What time are we finishing? 1. So we need to 1. Yeah? Okay, let me have this here so it will keep me on track. Okay, so inflammation, anti-inflammatory, analgesic, antipyretic. I was talking about pyrexia is what? Fever. So remember that's part of the function of prostaglandin as well. And the antiplatelet activity. Okay, so for to ensure that the platelets do not clump together, blood can flow freely. They also have a property. So they do good things. Prostaglandins have good activities, but on the other side, some things are not very nice about them as well. So if we, like when they cause pain and inflammation, and we want to stop that, because it's not a pleasant feeling. But if we stop the function of prostaglandin because we don't like it, sometimes we are not able to stop just the good parts. or the bad part that will go on, we also stop the good part. Okay? And when we stop the good part, what happens is that it becomes an adverse effect. Okay? So if you want to stop the pain, the fever, the inflammation, what about the ability of prostaglandin to protect our stomach from gastric acid? We stop that as well. And so our stomachs are exposed to the mucus produced to line the stomach walls is not going to be there because we have stopped prostaglandin. And so our stomachs are more at risk of being eroded by the gastric juices. So that's one of the downsides of stopping prostaglandins.
Is that why you are usually advised to take food before you take medication?
Yes. So certain medication you need to have a meal before you take them. So for some medication, that will be the reason. There will be numerous, depending on the medication, numerous reasons why. Some because they are nauseous, you want to take food before you take them. And some because they are absorbed faster with food. So you take, so they're different depending on the drug. But that's one of the reasons why you take food before you take your non-steroidal anti-inflammatory agents. So you have come to one of the patient education that we need to know when we're using non-steroidal anti-inflammatory agents is that our patients need to take food before they use this group or this class of drugs. Remember that this class of drugs will do what? Stop prostaglandin, reduce GIT mucosa protection. So you should be taking with food. Okay, so let's see. So basically, from arachidonic acid, we have those two enzymes that act on it to synthesize prostaglandin and your thromboxanes. And the third one is your, no, this is just your prostaglandin and thromboxane synthesis. So like we just discussed now, if we go back to where we talked about the different types of cyclooxygenase enzymes, or COX enzymes, we said there is COX-1, COX-2, COX-3. COX-1 produces prostaglandins that are specific. I'm not sure if you have that in the textbook. If it's there, is it there? Yes. So COX-1 produces prostaglandins that are responsible for
GIT, regulation of function of kidney, information of thrombosis.
Yes. And then COX-2
for prostaglandins that are
in the inflammatory process.
As well as nerve function.
Yeah. Yes. So if we stop COX-1, if we inhibit the activity of COX-1, what's going to happen from the prostaglandins that COX-1 makes? What are we going to see?
Will inhibit the protection of the GIT, and then the regulation of the function of the kidney. As well as the formation of thromboxane, which also involves platelet
aggregation. Then if we stop COX-2, we're going to stop what? Inflammation.
Yes.
Those prostaglandins are the ones responsible for the inflammatory process. So we stop them. So most non-steroidal anti-inflammatory agents, or the older ones, do not select, they just inhibit COX-1 and COX-2. So you use them, you get a relief, or you expose yourself to some other things. There's also the CVS risk associated with long-term use of non-steroidal anti-inflammatory agents as well. All right. So we saw the adverse effects that if we stop that, this can happen, and we would have. So your platelet aggregation. What happens with thromboxanes and platelet aggregation is hemorrhaging. Have you heard of your anticoagulants, coagulation? Have you done warfarin and all of those? Have you done human biology? Okay, those in human biology. So if we are inhibiting platelet aggregation, if someone has an injury, so in life has a positive side and there are the negative sides. So if someone has an injury and they've been on your non-steroidal anti-inflammatory agent, which has been inhibiting platelet aggregation, it means that they have an injury. It's going to take a long time for your coagulation cascade, human biology, okay? Your coagulation cascade to be formed, which means what will happen to the person? They will bleed more than necessary because of this effect of the non-steroidal anti-inflammatory agent. We already understand the renal disturbances. Also, one of the adverse effects of NSAIDs is its use in or by persons that are prone to asthma, asthmatic patients, or persons that have hypersensitivity. So if we inhibit the synthesis of prostaglandins that are active in bronchodilation, what would happen is we would have bronchoconstriction. Okay, that is one. There is also the leukotrienes. Remember, the leukotrienes are produced from arachidonic acid by your lipoxygenase enzyme. Okay, if we block the prostaglandin pathway, so like we said that in life there is no vacuum. Once you block something, nature finds another way to make sure life continues. All right. So once you block the prostaglandin pathway, the leukotriene, the lipoxygenase pathway, kicks in full force. And leukotrienes are responsible for vasoconstriction. Do we need to go back to? Should I go back to the slide? No. Vasoconstriction and inflammation. So if an asthma patient takes your non-steroidal anti-inflammatory agent and you block the prostaglandin pathway, the leukotriene pathway kicks in and it causes vasoconstriction and inflammation, which are what your bronchioles need for an asthma attack to ensue. So that's why we need to be very cautious when we give asthmatic patients non-steroidal anti-inflammatory agents. Am I making sense?
Yes.
So we need to be very careful when we give them this kind of medicines. So there's also the CNS effect. You can read up the other things. So we already know the therapeutic effects, the analgesia and antipyrexia and all of those things, and how this NSAIDs carry out these activities. So NSAIDs it's not all of them that carry out, that do the same thing or have the same effectiveness. Effectiveness will depend sometimes on the pharmacokinetics of the pharmacokinetic profile of the drug, of the NSAID that is being used, or possibly even the side effects that it will produce will determine what it can be used for. So we already talked about the GIT, and it shouldn't be used for long because of its GIT. So because of its ability to erode the mucosa, don't use it for too long. Then another NSAID, ketorolac, produces a synergistic activity with opioids. So if an opioid, so we have positive side, negative side. If an opioid analgesic, we'll do that later. Talking about your morphine, your codeine, those are called your opioid analgesics. It depends the nature of the pain. This determines the kind of analgesic you give. If it's very severe pain, like an accident, cancer, you use your opioids. Morphine is used in such cases because obviously you don't want to give paracetamol. It wouldn't do anything in that case. You have inflammation, you have severe pain, so you need something that will really work well. So, but you know, with opioids, they have the problem of what now? Addiction, dependence, tolerance, all of those things come along with using those drugs. So we can use something like your ketorolac. We can work with your opioids so that you don't have to use a high quantity of the opioids. So that's a synergistic effect that this has. When you choose this kind of you can combine it with opioids to reduce the dose of the opioids that is in there. So you can read up the other NSAIDs that are listed there, and then read up what is meant by combined NSAID. I think I just made mention of that now. That's the process where you combine an NSAID, an opioid, with either an NSAID or an analgesic agent. Also, I would like you to read up the patient's education for the choice of NSAIDs and for the precautions. I mentioned food before eating, some conditions that we need to look out for before prescribing or administering NSAIDs to our patients. So aspirin, is aspirin a non-steroidal anti-inflammatory agent? You think so? No. You don't think so? Doesn't think? Me not think. Okay, so we can say it is a non-steroidal anti-inflammatory agent, but it is not a traditional one. Okay, it's not a traditional one. It's an outlier. It has some funny stories about it, and this is because your non-steroidal anti-inflammatory agents will reversibly bind to cyclooxygenase enzyme, which is a right to for a while, and when it's exhausted, it leaves the enzyme to carry on with its life. But aspirin sits with the enzyme continually until the half-life can expire. So that's why it's said to be an irreversible blockage of cyclooxygenase. It kills the enzyme. Irreversible blockage of cyclooxygenase enzyme. So, and this results in, if it binds irreversibly with it, it produces prostaglandins and inhibits the production of the thromboxanes, because the production of prostaglandins takes preference over the production of thromboxanes. Okay? So you have it being, I would prefer that you go to the back. Sir? Next time. Don't walk out of my class right now. Okay. So, what was I saying then? So, because it inhibits the production of thromboxanes, because of its irreversible blockage, what happens with platelet aggregation, which is a main function of thromboxanes? So your aspirin will reduce or inhibit platelet aggregation continuously. Okay? So that's why you don't want to give it. No. Okay, good. Okay, so that's why you see in some cases of when they say they want to clean the blood, when you have thrombosis and all of those conditions where the blood needs to be made clean and to flow, then you can use aspirin. And that's why also are we aware of the low dose aspirin use for CVS, cardiovascular diseases? Because it helps to cleanse the blood and helps the blood to flow faster and better. So that's one of the good sides of it. But the bad side is that hemorrhaging, like we saw, would be an adverse effect for persons on aspirin. Okay? So it diminishes platelet adhesiveness and thrombus formation, what I've just said now. But unfortunately it has anti-inflammatory activity, it has pyresic activity, okay? It has analgesic activity. But the anti-inflammatory activity is at high doses. You need to give a lot of it for aspirin before you can see inflammation being reduced. And when you give a lot of it, what happens? The other side effects increase. So you don't want to use it for such conditions. There's also the Reyes syndrome in children with viral disease, that you don't give aspirin to children with viral disease because it can cause this syndrome. So you can read up the other things about aspirin there. Aspirin toxicity, okay, occurs, and the symptoms that accompany that is your tinnitus, lightheadedness, and all of that. Toxicity can be treated through the methods I've listed here, which are also in your texts. book. Have I missed something? I don't think I have. So we saw, this should have come before aspirin. We saw that non-steroidal anti-inflammatory agents can inhibit COX-1, COX-2, COX-3, and we have these different activities or different effects as a result of their inhibiting each of those COX enzymes. So we said that you read to me, she read to me earlier, that if non-steroidal anti-inflammatory agents inhibit COX-1, what's going to happen? Anybody else there? Can we go back to that page?
Production of glucose.
It's what?
We are using the production of glucose, production of
prostaglandins. That's what do these prostaglandins do? Remember I said there are different kinds of prostaglandins and each of them has its function. What do the prostaglandins do?
Pain, fever,
and inhibition. That's for COX-1. Then COX-2 will be the one that inhibits
inflammation.
Yes. So modern science, not very, it's been on for a while. So scientists and researchers and decided that if we need to inhibit COX-1 and COX-2 and we will produce this different effects, why don't we inhibit the one we want and leave the one we would rather still have to produce the prostaglandin that we still want that is useful to us? And that would be which prostaglandin? Which COX enzyme would we want to leave to continue working? We don't want to inhibit it because we love what it's doing. It's good for us. We want to. COX-2 is, look at it again, COX-2 is responsible for because COX-2 produces prostaglandins that are involved in inflammation. So if you want to stop inflammation and pain, you want to stop those prostaglandins. Remember. But the COX-1 enzyme produces prostaglandins that are involved in cytoprotection, renal autoregulation. We want those ones to continue. We love them. We need them for our own health and safety. So if we can stop just COX-2 and not stop COX-1, it would be nice. We stop pain, but we're still protected. Our kidneys are working fine, and all those other functions are going well. So this group of selective enzymes were developed, and this one only inhibits your COX-2 enzyme. You get it? Yes. So they only inhibit COX-2 enzyme, your cousin, heteroscousin, and cousin, inhibit only your COX-2 enzymes. So your cytoprotection, GIT cytoprotection continues, your autoregulation continues, and you're stopping pain, and you're stopping fever, and you're stopping inflammation. But adverse effects again, they have their own bad sides or downsides. Long use will increase risk of cardiovascular and cerebrovascular diseases because they also inhibit prostacyclin or PGI, which is responsible for those activities. All right, so we still haven't been able to win the battle yet because somewhere this still has a side effect. And also there is a very rare risk of, I don't know if you've heard of Stevens-Johnson's disease, or Stevens-Johnson syndrome rather. What's the name of this? A particular sulfonamide that causes that. What's it called? The cotrimoxazole. Yeah, cotrimoxazole. Your sulfamethyl. Okay. So that also is there. But they are useful. So persons with an active ulcer and they have a condition that they usually need analgesia for, they can use this drug and feel safer because they already have an ulcer, but their GIT cytoprotection is still intact because they're using the COX-2 NSAIDs. Okay, let's see. So we talk about analgesic agents. earlier. Analgesic just means the relief of pain. And the very good example is the paracetamol. Okay, paracetamol can be gotten over the counter. It only has analgesic activity and your pyrexic. You can stop pyrexia as well. And its mechanism of action is by inhibition of prostaglandins in the brain. It doesn't have peripheral activity. It only functions in the CNS. Okay. So that's paracetamol. So paracetamol also is toxic. Alright? It's usually a very safe drug, but if it's taken at about I think 10 milligrams of it is taken, or 10 grams, more than 10 grams, will lead to toxicity. And there is an antidote for paracetamol toxicity. Your N-acetylcysteine can be used for that. So, the mechanism of toxicity of paracetamol, I tried to compare it here. So what happens with paracetamol is that paracetamol itself, when it is taken, it is broken down into a toxic, okay, let's look at this one, into a toxic metabolite, which is your NAPPI. It is naturally toxic. The first metabolite product of, or metabolism product of paracetamol is toxic. But it reacts with your glutathione to form a non-toxic metabolite, which is now safe and can stay in the body. But in the case of an overdose, what happens is that the glutathione concentration is overwhelmed, and you cannot convert the paracetamol, the toxic metabolite, to the non-toxic, and so the toxic metabolite sits in the system and attacks the kidneys, the renal system, and then you have cell death, your necrosis, and cell death occurs as a result of that. Another group of anti-inflammatory agents is what is called your corticosteroids. Okay, so we said that the NSAIDs that we mentioned were non-steroidal anti-inflammatory agents. So your corticosteroids also have anti-inflammatory activity, but they are steroids. You get it? So we have the non-steroidal ones. Give me an example of the non-steroidal one. Analgesic. So we said analgesic is paracetamol. Non-steroidal anti-inflammatory agents. Ibuprofen. No, an example of a drug. Of a drug. Aspirin, well, not traditional, but aspirin would go. Ibuprofen. Paracetamol is an analgesic. Yes. Remember the one you differentiate between analgesia and your anti-inflammatory agent. And paracetamol doesn't have anti-inflammatory ability or property. So it's just an analgesic doing this is a painkiller. It only relieves pain. So when we talk about your non-steroidal anti-inflammatory agents, oh sorry, I don't have that on my slide. That's why. That's the reason why. So we have talking about your ibuprofen, your pyroxaban, methylamic acid, your diclofenac. Those are examples. It's in your textbook. And I think we'll start typing that all over on the slide. So those are examples of your non-steroidal anti-inflammatory agents. Did you get it? Is it clear? So analgesic, paracetamol. Non-steroidal anti-inflammatory agents, ibuprofen, pyroxaban, indomethacin. Tell me, which is that one? That one is a very popular one. Okay, so do we get it now? So those are non-steroidal. So we have another group of anti-inflammatory agents that are called corticosteroids. So that's why we needed that definition of non-steroidal, because this one are steroidal. Okay? These ones are steroids. Ibuprofen, paracetamol, paracetamol, diclofenac, and non-steroidal, but they have anti-inflammatory agents. But the third are anti-inflammatory agents, but they are steroids. So when you talk about steroids, what do we know about steroids? Anybody know anything about steroids? The what? Lipids. Okay. What did you say? Okay. Anybody else? When we talk about steroids, let's think about an athlete. Pardon? Steroid, yes. They could be, yes. Someone uses. So they have some anabolic properties that makes it important to be very careful with the use of steroids. So they are classified either as mineralocorticoids or glucocorticoids. Okay? Mineralocorticoids will be the ones that act with salt and water excretion or metabolism in the body. While your glucocorticoids help with a lot of, they have a lot of function in the body. The synthesis of glucocorticoids is explained here. Quite easy. So they are, the glucocorticoids are synthesized from cholesterol. Someone mentioned cholesterol, now I want to know a third. So they are synthesized from cholesterol. Just read that. So how do they act now? What do they do? So your glucocorticoids interact with receptors again. Remember we said they have anti-inflammatory activity. So your glucocorticoids interact with intracellular receptors and they form a compound which is called your lipoprotein. Lipoprotein also has the ability to inhibit your phospholipidase A2 from being converted to arachidonic acid. Do we see where the anti-inflammatory activity comes from? Do we understand it? So your steroidal anti-inflammatory agents, corticosteroids, have the ability to inhibit phospholipidase A2, which is, remember, that's the enzyme that converts your phospholipidase to arachidonic acid. So in any of those pathways, I could do biochemistry. Human biology. Do you do biochemistry in human biology? When do you do biochemistry? You'll see all those pathways in biochemistry. Okay, so they inhibit the phospholipidase A2 enzyme, which converts phospholipids to arachidonic acid. Remember what we don't want is arachidonic acid, because arachidonic acid becomes prostaglandin. So anything that can stop arachidonic acid, anytime, anywhere, is welcome, and it will become an anti-inflammatory agent, because it's going to stop the inflammatory process, or inflammation process. So, in addition to doing that, they also have many other anti-inflammatory activities. They also inhibit many other pathways. So, what is the pharmacological effect? They are anti-inflammatory, they are anti-allergic because they suppress antibody production in large doses. Okay, they're immunosuppressive. So, I don't know if you've heard that someone who is on a corticosteroid, for example, prednisone, has a reduced immunity. I don't know if you've never heard about it. Like persons that have some certain diseases and they need to be on continuous corticosteroid, they are said to be of reduced immunity, immunocompromised. That's the word. They're said to be immunocompromised because of the lysis of lymphoid tissue. That's where your leukocytes reside. And once you cause have you done HIV? So you see how the HIV virus affects the CD4 T cells. It kills them, isn't it? So what happens to immunity when that happens? So that's why the patient becomes immunocompromised. So if we also, so this is part of your immune system. If we also lyse the lymphoid tissue, which has our leukocytes that help us with immunity, what happens? You reduce the immunity of the patient. So that's why you learn more about it, I guess, as you go on. Why patients on corticosteroids are said to have been immunocompromised, and they wouldn't give them some vaccines. And they tell them to be careful when you have TB patients around because their body system cannot fight infections because of the license of. Okay, let's go on. Yes, metabolism as well. That is for diabetic patients, when they use glucocorticoids, it increases the sugar in their system because of your gluconeogenesis or the glycogen processes. So glucose is stored, is manufactured more because of the presence of your steroids. One other thing to take note of with your corticosteroid is that once a patient begins to use them, okay, the patient should use low doses. Usually we want to start patients on a very low dose and keep it for as short a time as possible. You don't want to give it for too long and give it in high doses because it has adverse effects on the patient. It's what's called Cushing's syndrome. It causes Cushing's syndrome in the patient, and so you want to be very careful. And so also, because the glucocorticoids are natural to the body, okay? They're natural to the body, so the body produces them naturally. When we introduce more, we distort the body's natural mechanism. We distort the body's natural mechanism. So when we increase the dose, and the patient needs to stop taking it, we need to do it gradually, so the body doesn't pump the synthesis of the glucocorticoids too much to cause a problem for the patient. So we withdraw the medication slowly. Either the patient starts taking it every other day rather than every day, or you reduce the dose the patient takes daily. So usually you don't want to give a patient for more than 10 days if it is avoidable. So because it's an anti-inflammatory agent, remember we said with asthma, nutrients play parts in asthma because they cause inflammation and vasoconstriction. So glucocorticoids or corticosteroids play a major part in the treatment of asthma patients. In fact, if every other thing fails, you just need to give an oral corticosteroid like prednisone to the patient, and it inhibits that inflammation pathway immediately. So some other therapeutic uses are indicated here. You can quickly read that off. Another condition that requires the use of anti-inflammatory agents is rheumatoid arthritis. Rheumatoid arthritis. And this is the chronic inflammatory condition that affects the joints. It's also an autoimmune condition in that sometimes the body just attacks itself. And then you have these conditions arising. So it has an inflammatory component, and then there is the proliferation of the synovium, and what really causes the physical damage is the erosion of the cartilage and the bones of the affected patient. So there is a loss of cartilage and there is chronic inflammation with rheumatoid arthritis. This is an example of the pathogenesis of rheumatoid arthritis. And this is what a person with rheumatoid, you see the bones are funny shaped and like that. Okay. So symptoms of rheumatoid arthritis are listed here. Therapy. So we've already mentioned the non-steroidal anti-inflammatory agents. We've mentioned analgesics like paracetamol. We've mentioned corticosteroids to be used for inflammation. So when we want to treat rheumatoid arthritis, the goal of therapy is to improve or maintain the function of the body. You saw how deformed that part of the body we saw was. So it's not going to be easy for the person to be able to use that part of the body or to keep the function of that part of the body. So when we want to treat that condition, we want to try to improve the patient's ability to maintain the function, then control the disease activity and the pain that are associated with it, and the destruction that follows the condition. Non-pharmacological therapy talks about therapy that doesn't involve use of medicine. Okay, so the patient can be counseled in this. So for pharmacotherapy, because inflammation is a major underlying factor for rheumatoid arthritis, you also want to treat with your NSAIDs. You also want to treat with your NSAIDs and your corticosteroids as well. But sometimes this doesn't work for some patients. So there is another group of anti-inflammatory agents that works for rheumatoid arthritis, and they are called your DMARDs. Okay? Your disease-modifying anti-rheumatoid drugs. There is also another group of anti-inflammatory agents, which is referred to as your immunosuppressants, and they're biologic agents that are also used in the treatment of rheumatoid arthritis. We already know about non-steroidal anti-inflammatory agents. I think recently it's been advised that you should start with the DMARDs rather than waiting to use the NSAIDs first. So we see our synthetic disease modifying synthetic DMARDs are outlined here. So if it could be second line, but you can start with it also. Once it is confirmed that what the patient has is rheumatoid arthritis, then DMARDs can be used in the treatment. So these ones are able to halt or reverse the underlying disease, the bone of disease or the damage to the bone and the joints. Unlike your corticosteroids and your, what's the other one? NSAIDs that would relieve the pain. DMARDs would restore, would help to reverse or halt the destruction of the bone and the joints that cause. But they have very serious adverse effects. And because of these adverse effects, a lot of patients do not adhere. The compliance is quite low with the use of this condition. Example of your synthetic DMARD would be your methotrexate, all right, and cyclosporine. Then we have DMARDs that are anti-malarial agents, but they work for rheumatoid arthritis as well. Chloroquine and hydroxychloroquine will work for rheumatoid arthritis. What I want to take note of is the mechanism of action of this agents, okay, of this anti-inflammatory agents that I use for this condition. The mechanism of action, like for methotrexate, it's a folic acid antagonist, okay? It's a folic acid antagonist, which means when the patient uses that, their ability to uptake folic acid is inhibited. Their ability to uptake folic acid is inhibited and they become folic acid deficient. So it is advised that you give folic acid to such patients that are on methotrexate because they antagonize the body's ability to take such drugs. Then we have the cyclosporines. Giving to patients who don't respond to convenient therapy. The adverse effects also are a problem here because of the nephrotoxicity. Your anti-malaria agents, the mechanism of action is not very clear, but you have an example there. Then you have another group called your sulfasalazine, also used in the treatment of rheumatoid arthritis. Our biologic DMARDs would be your TNF alpha antagonist, rituximab is another example. So these ones are biologic preparations that are used for rheumatoid arthritis. But usually they're used in combination with methotrexate. And one thing you would always want to remember about methotrexate is that it's a folic acid antagonist. It's a common question that usually comes up. So these ones have very positive clinical outcomes, but they have the ability to cause immunosuppression in the patients that use them. And with immunosuppression, what happens? Immunocompromised. When patients are on these medications, they have an increased risk of getting infected with any kind of infection, like you have your opportunistic infections in HIV. Okay, another DMAT there. Sorry, that slide is, they're running into each other. Anakinran is another one. Another condition that requires the use of anti-inflammatory agents is gout. Gout also requires the use of anti-inflammatory agents. He said, can anyone remember the definition I gave for rheumatoid arthritis? Or even look through your textbook and tell me what it says about rheumatoid arthritis. But we want to differentiate between gout and rheumatoid arthritis. What does we say rheumatoid arthritis is? A chronic inflammatory condition that affects the joints. That's all rheumatoid arthritis, and you have the inflammation of the synovial fluid as well. And inflammation of foreign. With gout, does anyone know anything about gout here? Anything about gout? So with gout, the thing to remember when you hear the word gout, so when you hear rheumatoid arthritis, you see RA or OA, okay? Those are types of rheumatoid arthritis. When you hear rheumatoid arthritis, you want to think of, what was the definition again? Joints deformation with rheumatoid arthritis. When you hear the word gout, you want to think of uric acid. Okay? So it's a condition that has to do with uric acid levels in the body. So that's what differentiates the two conditions. And when you talk about rheumatoid arthritis, you will think DMARDs. Synthetic and biologic DMARDs that are used for rheumatoid arthritis. So let's see what is used for gout. So uric acid is naturally produced in the body. Okay? But when there is an overproduction, that's when you have your hyperuricemia, an overproduction of uric acid in the body, okay? Then you have your hyperuricemia, and there is a deposition in the joints as well. So when the uric acid is deposited in the joints, because it's more than what the body can cope with, so the body is trying to just store it where it can, and then it goes into the synovial fluids of the joints, it initiates. Remember I said that once anything invades the body that shouldn't be there, what does the body's police do? Neurotransmitters are released to say someone is invading us. Okay, so you have even autoimmune diseases where the body thinks its own self is invading it and attacks it in the immune system. Okay? So once you have that deposition of uric acid in the joints and all of those places, an inflammatory response occurs because they shouldn't be there. Okay? Because they shouldn't be in those places, an inflammatory process occurs, and that is what leads to your gouty arthritis. So your inflammatory response involves local infiltration. So when it's stored away in those places, the body calls its soldiers, the leukocytes, the phagocytes, come, let's get rid of this invading or unwanted substance that is present here. And in the process of your phagocytosis, what is produced is lactic acid. And a lot of lactic acid is produced in the process of trying to get rid of the uric acid. By producing lactic acid, they lower the pH of the environment, and more uric acid is formed in the process. So in trying to get rid of uric acid, the body trying to get rid of uric acid, it starts a reaction that lowers pH, and that lowering of the pH is conducive for the crystallization of uric acid. So it's not helping itself in any way by introducing that response. And so it's also very, very painful. It has to do with pain. And usually it starts in the big toe. The big toe of the leg. So you have a patient complaining about the pain in the big toe, or it can be on some other parts of the body. And you want to do a uric acid test to find out. Some food that we eat can also precipitate or predispose us to gouty arthritis, like your red meat and all of those other things that are mentioned there. So purine is what you will find from the food that I just talked about now. And when you metabolize that, then you have uric acid. So hyperuricemia shouldn't be a normal situation in an individual. But when it happens, it's either because there is increased metabolism of metabolism which produces more uric acid than necessary, or the kidneys are not taking out the uric acid as quickly as they should. So there is an accumulation of uric acid. So if we want to treat this condition, okay, this is an example of someone who has a gouty arthritis. No, not here. This is how it is stored away in the joints. This is an example of a patient with gouty arthritis. So if we want to treat this condition, we can treat the acute attack, or we can we treat the acute condition when it comes on suddenly for the first time, or for persons that are prone to recurrent exposures or incidences, we do a maintenance therapy for hyperuricemia. Some persons that are prone to having that condition continuously. When we want to treat the acute attack, we want to relieve inflammation. So that's why it falls under our inflammatory agents. We want to relieve inflammation. How did the inflammation come about? Because of the deposition of uric acid in the joints. The body initiates an inflammatory response, remember, and that is how the inflammation, so you have the swelling occurring as a result of that inflammatory response. So once we relieve inflammation, relieve the pain, and reduce the uric acid levels in the patient. Reduce the uric acid level in the patient. But our non-steroidal anti-inflammatory agents and our corticosteroids also, they are all inflammatory agents, will not reduce the uric acid level, but it will help with the pain and the inflammation. Do we agree? They will help with pain and inflammation, but they will not reduce the uric acid level. So we can start with those ones, and then if the response is not very good, then we go to the main drugs that are used for the treatment of acute gout. And that would be colchicine. Okay? Colchicine is an anti-inflammatory agent that is used in the treatment of acute gout. Take note of the fact of the post-acute gout. Because if there is an acute condition, what else do you expect to be present? If there is an acute condition, what would be like not opposites, what would be the other thing that you would see? Have you someone seen something that sounds like what I want to hear?
Pain.
Huh?
I see pain.
Pain. Okay. So if there's an acute condition, there would be a chronic condition. Okay? So if there's an acute condition, there will be a chronic condition. The acute conditions are very quick onset, starts now. You feel the pain, you go through the turbulence and then it stops within a few days. But the chronic condition starts slowly. You know our chronic conditions. Slowly, it goes up, and sometimes you can't treat it. You need to manage it for the rest of the life because it starts slowly and grows up. That's because of the acute and chronic conditions. So, colchicine is effective for treatment of acute gout, which means it is not very effective in the treatment of chronic incidences of gout. We will need to use another anti-inflammatory agent in that situation. So because it's very effective against gouty arthritis, it can also be used to diagnose if a patient has acute gout. If it responds to colchicine, then you can confirm that. Did you see those two pictures that I showed you? The rheumatoid arthritis patient and the gout patient. Could you tell the difference from looking at the clinical presentation, the physical presentation of the condition? Could you tell the difference easily? Sometimes it might be cold. So, but use of colchicine can be used to determine. All right. So what it does, the mechanism of action, so take note of your mechanism of actions. Your mechanism of action, what does it tell you? What does the mechanism of action tell you? How the drug works. Okay? What it does to create the pharmacological activity that will produce, or that will stop the disease, or halt the disease, or reduce the symptoms that we see in the patient. We love our mechanisms of action. We always ask about them because if you know the mechanism of action, you can twist the drug anyhow. You can fit it into different situations and say, okay, if this is what is wrong with this patient, then if this is what is wrong with this patient and this is what this drug does, then this drug will be suitable for this condition. Because I know how the drug works, and this patient is presented with a situation that the drug can work with. And so it will be suitable to be used for such patients. So we said with gout, inflammatory response is induced or elicited by the accumulation of uric acid in the joints and synovial fluids, and then when we have the importation of your leukocytes and your phagocytes, as they try to get rid of that, the inflammation increases and all of that. So the mechanism of action naturally for colchicine would be to reduce the phagocytic action of leukocytes, because that is what is causing the inflammation. Remember, to cure a disease, to stop something, look for what is causing it and take it out. Once you take what is causing it out, you've stopped the process. Okay, so it reduces the phagocytic action of leukocytes, and so it reduces the inflammatory response. Does that make sense to you? Reduces inflammation because phagocytes and leukocyte activity is reduced. So when that happens also, what happens to, because we said that the phagocytic activity of your leukocytes is what releases lactic acid. And so once we stop phagocytes and leukocytes, what happens to lactic acid? It reduces as well. And once lactic acid reduces, what happens to the crystallization of uric acid? It stops, because the pH is no longer reducing. What was creating the enabling environment was the pH as a result of the lactic acid. Once you take that out, crystallization of uric acid also is inhibited. So these things, just to understand that one thing leads to the other. You stop one thing, stop phagocytic activity, stop lactic acid, stops crystallization of uric acid, patient feels better. Okay? So patient feels better. All right, I think I'm going to finish early. So the side effects, you can read that, and then the dose, you can read that as well. So To give a maintenance therapy for persons, so we said an acute attack comes on suddenly, and it can happen quickly. You go through the inflammatory process, go through all the troubles and whatever, and then it's treated and it's gone. But if you have someone who keeps having a recurring incidence of that condition, then it's tending towards a chronic situation. Then you need to have a maintenance therapy to help the person reduce the frequency of experiencing that condition. Okay? So you put a maintenance therapy in place to reduce the frequency of that experience. So this is where the difference between your acute, the drug that can be used for acute gout and the one that can be used for chronic condition comes into play. Remember, for the acute, we said colchicine would work for acute. But if you want to do a maintenance therapy for a situation tending towards chronic experience, we cannot use colchicine. So the drug we use here is another anti-inflammatory agent called allopurinol. So you've heard about a lot of anti-inflammatory agents this afternoon. I hope you'll be able to remember them in my next class. So allopurinol. Colchicine for acute condition. Allopurinol for maintenance therapy, which will be your chronic condition now, because that means the person needs to take it. Maintenance. When you maintain something, you do it often so the thing doesn't spoil. Alright. So allopurinol will be used for that. It reduces uric acid synthesis. It inhibits xanthine oxidase. If you look at the way uric acid is synthesized in the body, you see that pathway. It's in your textbook. The xanthine, I don't have the page here. The xanthine and what's the other one? The pathway which your xanthine oxidase enzyme is involved in, okay? So with allopurinol, what happens is that once it is used, it causes a sudden reduction in uric acid levels in the body. And when this happens, the body tries to make up for it and tries to increase the level back to where it was. So the patients are advised that before they start the uric acid, they should use prophylactic therapy along with allopurinol, so that it doesn't revert back. The body doesn't revert back to replace the uric acid that's been taken out if we have that prophylactic therapy in place. So it's a drug of choice for long-term treatment. So it is not useful for acute attacks of gout. And so how it does its work is by inhibiting the synthesis of uric acid. Allopurinol is a uric acid inhibitor. Okay? Allopurinol is a uric acid inhibitor, so it inhibits the synthesis of uric acid. So for your maintenance therapy, you can do it in two ways. You can have your inhibition of the synthesis of uric acid, or you can have where you assist the kidney to increase the elimination, to aid potentiate the elimination of the uric acid. So allopurinol will inhibit synthesis, while our probenecid will help the kidney to accelerate the elimination of uric acid. And the mechanism of action is stated there. Okay. So we've talked about gout. We've talked about, let's start from the beginning. How many minutes do I have? I have 25. So let's do a recap before I go to migraine. Migraine, I don't have much of migraine. I think I'll continue with that next class. What? So we started with pain, analgesia. Okay? Just painkillers. And we said analgesia is also the relief of pain. And the drug, if you are asked to mention an analgesic agent, which drug would you mention? paracetamol. So from paracetamol, so we said paracetamol can induce an analgesia, relief pain. What else can it do? Fever. And fever would be pyrexia. Let's stop that. Okay. So pyrexia would be the relief of fever. Okay. So we have analgesic agents there. Then we talked about some other drugs. So our paracetamol does not have anti-inflammatory agents. So if I have a big boil on my head or a bump on my head and I'm using paracetamol, no, it will relieve my pain. It will relieve my pain, but the swelling will take its time. It will go through the natural process of reducing. But if I use an anti-inflammatory agent, it will help to reduce the swelling. What else will it do? Relieve the pain. If there is a fever, it can also reduce the fever. Okay, so that's your anti-inflammatory agent. So we saw with our anti-inflammatory agents, we have two groups. We have the non-steroidal anti-inflammatory agents, and then we have the steroidal anti-inflammatory agents. Okay, so an example of our non-steroidal anti-inflammatory agent would be aspirin, ibuprofen, paroxetine, diclofenac, methylamic acid. You have a list in your text. So those are non-steroidal anti-inflammatory agents. So they do not have steroidal property. But they can reduce inflammation, they can relieve pain, and they can also deal with pyrexia. And what some other things that we saw, platelet aggregation, okay, mucosal protection. We saw those they can do that. No, not the agents. They can inhibit that. So we learned about prostaglandins and all of that, how it functions in the non-steroidal anti-inflammatory agent. So after we saw the non-steroidal, then we looked at the steroidal anti-inflammatory agents, isn't it? Example of a steroidal anti-inflammatory agents. So what are your steroidal anti-inflammatory agents called? Corticosteroids. So you have corticosteroids, you're correct. Corticosteroids, so we have two classes. They can be your glucocorticoids or your mineralocorticoids. Okay. So look through your textbook, you'll see examples. The names, your mineralocorticoids, give me a name. That would be a glucocorticoid. Prednisone is a glucocorticoid. Ibuprofen, dexamethasone, those are all your glucocorticoids. Your mineralocorticoids, give me a name. So that's your mineralocorticoid. And those ones work more with electrolytes and water retention. So sometimes, okay, so you have those two different groups of, but with this class of drugs, like with your NSAIDs, we need to be careful because we have some good sides and we have some bad sides, and we need to, as healthcare professionals, we need to know when to use them and when not to use them. So I would love you to read your patient's education in your textbook. So that's how you be able to manage the patients properly when you give them the medication, so they won't suffer from the adverse effects of such medication. All right, so with our corticosteroids, we saw that it can cause Cushing's syndrome, so we need to be careful when we use it. You know, it causes the fat deposition or accumulation, which is the hump that you would see in some persons. It causes weight gain, okay, increases metabolism, and some other things that adverse effects that come along with its use. So it is really advised that it's used for a short term in the smallest possible effective dose. And then you've got asthma. Prof. Vicky taught you asthma. Am I correct? So you're already aware of the use of corticosteroids in the treatment of asthma, which is what I also mentioned earlier. Okay, with the nutrients, the inhibition of the prostaglandin pathway, or the enhancing of the leukotriene pathway, which leads to your vasoconstriction and inflammation in Okay, so corticosteroids, yes. So from corticosteroids, now we look at diseases that need the use of anti-inflammatory agents. And the first one we looked at was rheumatoid arthritis. We saw it's a condition that has to do with what? Joints and bone destruction. Okay, and inflammatory action that affects joints and bone destruction, erosion. And the drugs that we saw there, so we saw because it's an inflammatory condition, we can use our corticosteroids, we can use our NSAIDs as well, but we did not mention paracetamol. Why not? Don't take pain away. That does not seem effective. If you say don't take pain away, you have to tell me where we can. That is the story. It doesn't have anti-inflammatory. That's the point here. But if you want an anti-inflammatory condition, don't focus on the pain. Focus on inflammation. Okay? So because it doesn't have anti-inflammatory property, that's why we're not mentioning paracetamol for this condition. Alright? So we saw also that there are other groups of anti-inflammatory agents that are suitable for this condition because of the pathogenesis. It involves bone erosion, alright? What can stop that? Then we saw our DMATs, synthetic and biologic DMATs. Am I right? Is it DMATs for rheumatoid arthritis? Then we saw, I think, anti-malaria agents also, a part of the DMAT, the methotrexate, cyclosporine, and all of those are part of your DMATs. Then we looked at gout, and we saw gout is uric acid. And it's an anti-inflammatory condition caused by the deposition of uric acid in the joints, which makes the body to fight, and the body wants to remove the uric acid, and because of removing the uric acid, it causes the inflammatory process and makes the situation worse. So we need something that will stop the activity of the phagocytic activity of the immune system so that we can stop the crystallization of uric acid. Alright? So we saw colchicine for acute gout. We saw what else? Chronic gout is allopurinol for chronic gout. Okay? Then we saw probenecid as well. But each of them works in two different ways for the maintenance therapy. Okay. Should I just start this migraine next class? It's also part of the studies. Are you full? You're saturated? Okay, so I'll see you next week.